Welcome, everyone. It is such a pleasure to introduce you, Bhavani. I have known Bhavani for almost 25 years now. We both did our optometry from the same college in India. She was a trailblazer then, and she continues to be a trailblazer today in the field that she's working in. She's done such a wonderful job. She's a director of the Dan Arnold Center of Vision Rehabilitation at the Robert Cizik Eye Clinic. She is also a clinical associate professor at the Ruiz Department of Ophthalmology and Vision Science at McGovern Medical School at the University of Texas Health Science Center at Houston. This is a huge achievement because in an ophthalmology department, for an optometrist to get into an associate professor level is unheard of. So this is something she has achieved. That is fantastic. Kudos to you, Bhavani. We are so looking forward to hear your talk on the advances in low vision technology. Thank you so much for being part of this webinar organized by Vision Aid. We certainly appreciate your time in this busy time period as well. Without much ado, here you go, Bhavani.
Thank you so much, Aparna. Thank you, Ram, for inviting me to do this talk. Really honored and privileged to see so many of you sign in. And I hope I do justice to your time and Aparna's efforts. And thank you to Vision Aid for putting this together. So let me go ahead and share my screen with you. And all right. So as Aparna just said, I am the director for the Dan Arnold Center for Vision Rehabilitation. I started this clinic about 12, 13 years ago in 2007 to be precise, actually. And it was a time when there wasn't much happening in Houston. So there was a low vision clinic run by the optometry school, which is still there. But there was really nothing where patients could come and meet the doctor directly and talk and find out how to get help. And that's how the whole clinic started. And that's a long story. Fast forward 13 years, here we are. This is one of the leading clinics on this side of the country. And we have a 300-mile footprint. So we draw from a very wide range, very wide area. And we see a lot of patients of all age groups, all the way from 3 months, all the way up to 106 years of age. So the topic that I was requested to speak on was about advances in low vision technology, like where are we at right now? But I think before we talk about low vision devices, I think it is imperative to talk about magnification in general and how vision rehabilitation can help, because it is a full picture, right? It is the whole gamut that actually makes the difference. It's not just the devices by themselves that make the difference. It's not the evaluation by itself that makes the difference. It's not the training by itself that makes the difference. It's not just one piece. It's actually the whole model is what makes the difference. And I really hope that you understand that when we talk about devices, it is not just that the device is going to solve all their problems. You have to think of the full picture, and device is just one small piece of what that picture is. So moving on, of course, lemons to lemonade, right? Like, how can vision rehabilitation help when life deals you a lemon? I think what we need to understand is vision loss in any amount compromises function more than any other single physical impairment. It compromises your function more than losing both your legs. And people fear vision loss more than loss of mental capacity. And I think that is extremely important to recognize and acknowledge. Comprehensive vision rehabilitation is a team effort, actually. It's got two distinct parts. There's the low vision evaluation that is done by the OD or OM ophthalmologists in some places, or it might be a team of OD and ophthalmologists, or it could be a team of OD, OMD, and actually rehabilitation therapists. So we have an occupational therapist on our staff that works with our patients. In fact, our team actually comprises of myself, that's an optometrist. And then I have an occupational therapist that provides the training for the patients. And we also have an orientation mobility specialist that teaches these patients how to walk with a blind cane or how to cross street and whatnot. And we have a loaner library of devices that we actually give to patients so that they can try these devices without feeling the need to purchase everything that they see. We'll talk more about that. But the crux of this talk is to talk more about the low vision devices themselves. A low vision evaluation should include all of these, ideally. A thorough functional history, measuring visual acuity, contrast sensitivity, plotting the blind spots. In our clinic, we do what's called as microperimetry. Not every clinic is equipped with a microperimeter. You should at least be doing an AMSLA grid, or perhaps the California test. There's a little, they use a little flashlight, it's like a laser light actually. And then there's a piece of paper that they hold it with, and we are able to map out the blind spots in the middle of their vision. Some sort of blind spot monitoring should be done. Exposure to magnifying devices, which is what we're going to talk about today. And of course, counseling, education, and resources, all of which are absolutely important. So I sort of want you to kind of imprint this model into your head and sort of see how you can plug things in and make it work for your patients. Magnification is your friend. There are different types of magnification, right? There's relative distance magnification, there's relative size magnification, there's angular magnification, and electronic magnification. I'm going to try and make it as simple as possible, since I'm not certain at the level of knowledge of everybody on the presentation here, in the audience here. So I want to make sure that each of you have at least something that you can walk away with from the presentation and have it not be at such a high level that you don't get anything out of it. So when we talk about relative distance magnification, basically we're talking about bringing something closer to you. So an object that's brought closer to you takes up larger room in your retina. It causes a bigger retinal image, and that's what we call as a relative distance magnification. And of course, when you use relative distance magnification, you have to have appropriate reading glasses in order to allow that image to be focused onto the retina. So relative distance magnification is a very, very simple form of magnification you can give. Making it bigger. Relative size magnification. So the picture on the left, the smaller phone might be difficult for patients to see, but the moment you increase that size, a larger object takes up more room in your retina, and that is relative size magnification without changing anything else. And there's optical magnification. We call it angular magnification. Handheld devices like lighted handheld magnifiers are very, very simple forms of giving that kind of magnification. They range in power all the way from 3 times up to like 16 times, sometimes even more than that. Of course, with each type of magnification comes some advantages and some disadvantages, right? Like with relative size magnification, you can't make everything bigger. Same thing with relative distance magnification. You cannot bring everything closer to you. So optical magnification provides a very easy and quick way to provide that magnification. The limitations with optical magnification is that you're limited by the law of optics, physics, right? The size of the lens itself is a limiting factor. Higher the magnification, the smaller the lens size. So the field of view is pretty limited. So handheld magnifiers are not necessarily a solution for every task, but for some tasks, those are very good because you can quickly pull it out of your purse and take it grocery shopping. If you want to see the nutrition label on the back of a can or heating instructions on a box, then you need to be able to see what the instructions say, and these are a great way to provide that magnification. So when we assess patients, we look at their entering acuity and determine what their goal is and calculate how much magnification a person is going to need. I'm not going to go into how to calculate magnification because that's kind of not the point of this talk. The point of this talk is to find out more about what's out there, right? So we'll kind of touch upon it, but basically sort of curse over it so we can move on to the next point. But optical handheld magnifiers are a great way to provide quick magnification. If somebody wants to turn on their stove and needs to be able to see the dial, it's a great way to provide that. If they want to read their price tag at the store, then that's a great way to provide that. Would I have my patient read newspaper with that? Maybe not, right? Because the field of view is so small that in order to read newspaper, you want to have continuous print and you want to have a good field of view, otherwise it slows you down. So handheld magnifiers, though inexpensive and quick and easy to grab and move on, are not a great option for continuous or prolonged reading activities. And that's the point I'm trying to make. Stand magnifiers are, on the other hand, work slightly differently. Stand magnifiers, they should have called it sit magnifiers because they actually sit on top of the paper. They don't stand on top of the paper. And the way they created the stand magnifier is that there is actually a virtual image that's created somewhere between the top of that lens and your eye. So in order for it to allow divergent rays to come out of that lens, so that height of that stand magnifier that you see is not actually set to the height of that focal point of that lens that they have used. Once again, this is going a little bit deeper into the optics, but those of you that understand the optics behind it will understand that you're actually, they're producing a virtual image somewhere above that lens so that divergent rays come out of the magnifier so that you have a better field of view. The nice thing about stand magnifiers is that you can put it right on top of the paper and move it along. So it's more appropriate for somebody that has tremors, or if they have, if they're not able to hold their hand steady on top of the paper, then a stand magnifier, which actually literally sits on top of the paper, is a more appropriate option for somebody like that. And of course, when you prescribe stand magnifiers, you also have to take into consideration the reading add power that the patient is wearing and make sure that you're providing adequate add power to compensate for the divergent light coming out of that stand magnifier. A lot of manufacturers will actually declare the virtual image distance, or some manufacturers actually give you the strongest add power that you can prescribe. If you have that readily available, then it makes your job easier. If not, then you have to go through and mark each and every one of them. Stand magnifiers tend to work better in the lower power ranges. I personally have not had a lot of success in prescribing stand magnifiers for patients that want to do prolonged reading, especially at the higher power ranges. These once again range in power from 3 times all the way up to 16, 18 times in some cases, or 12.5 times is the highest that I have seen. But I think there are some out there that do go higher than that. So stand magnifiers, I think there are better magnification options for higher powers than stand magnifiers. So my go-to would be for the lower powers, I like the stand magnifiers, but when I go into higher powers, I want to have something that's got a little bit better field of view. And of course, there are spectacle mounted magnifiers like these, where if they want to do something hands-free, then they can wear it right on their head. And it's called a Walters head mount, and use that for like tightening a screw, for instance, or perhaps opening a can of soup. These tend to be very low in power though. Of course, electronic magnification. So when you come to higher power ranges, like I said, electronic magnification might be a better option because you have a huge screen. You have the screen size ranges all the way from like 18 inches up to 22, 26 inches, sometimes 28 inches. So you're not limited by the screen size, and you have magnification ranging all the way from like 3 or even 4 times up to 64, maybe 80, 85 times, depending on the screen size. So you have a very, very large range of magnification that you can provide. nice thing about electronic magnification is it's retro-lit. It's lit from the back. So you have a bright image. You can manipulate the contrast. Anytime contrast sensitivity needs to be manipulated, which I hope y'all are measuring in your clinic. So anytime contrast sensitivity needs to be manipulated, then electronic magnification is a wonderful option. And sometimes, particularly with macular degeneration or even glaucoma for that instance, early macular degeneration, where their acuity might be pretty good. They may still have 20/40, 20/50 acuity. For those of you in India, that would be 6/12 or 6/24 acuity. But the problem is their contrast may be less. Or they may have a blind spot right in the middle of their vision that they're looking through, and that interferes with the way they read. Having it spread across the screen like that allows for some visual closure. So even if a letter or half a letter is missing, it's a lot easier for the patient to read. With electronic magnification, this is just one model that I have shown here. This child is actually reading his book. So they put the book underneath. There's a camera up there, and I think you can see it better in the next picture. But there different models exist. And just a disclaimer, I don't have stocks or any kind of financial interest, sadly, in any of these products that I'm about to show you. But just so you know, this happens to be one that was in the clinic. And so you have a line, there's like a reading line that comes up that makes it easier for the child to find his space. Especially with children with nystagmus, they have what's called this crowding phenomenon, where if you give them too much to look at, because of that movement of the eye, because of the nystagmus movement of the eye, they lose their place very easily. Or if it is a person with macular degeneration and a scotoma to the right of fixation, then when they read along, that scotoma moves along into the next word, causing them to lose their space. Or if they have a blind spot to the left of their fixation, then coming back to the start of the next line may be difficult and they may lose their place easily. So in those cases, having that kind of a reading line makes a big, big difference and makes it easier for them. This is an arm-based CCTV once again. And if you see here, she has turned, that's the camera right there. So the camera can be faced down towards the object on the floor, on the table, or it can be turned the way she has turned it and she's applying makeup. So it can be used for personal grooming. It can be used for, putting nail polish on or maybe writing a check. They can get their hand underneath here. It doesn't matter how big it is. As long as it fits on there, between this and this, it's gonna be just fine. My only recommendation to patients is to try not to trim their toenails under it, because I had one person that actually called me at 10 o'clock at night and said they couldn't get their foot off the table because they tried to trim their toenails under the machine. So except for, wacky tricks like that, pretty much anything can fit under there. They can do their craft work under there. They can read a book under there. They can write a check. They can do their bills, and they can magnify it all the way from 5 times up to 64, 80 times. It doesn't matter. You can just go as high as you want. And it just depends on the size of the screen. Now, kind of reverting back to children, tablet-based CCTVs are very, very popular amongst kids. Like for children that are like between 5 and up to about 12 years of age, when they start getting ready to go into middle school, a desktop CCTV is a wonderful option because they're not really going from class to class. Unlike in India, in the US, children actually go from class to class. There the teacher comes to you. Here you go to the teacher. So having a child schlep a CCTV from room to room is just not practical. It works better in the elementary level because there the teacher comes to you and there are very few rooms that they go to. They're usually in the same room most of the day. So it's a lot easier for the elementary school kids to use a desktop CCTV. But the moment we go to middle school, a portable or a luggable CCTV becomes a lot more applicable. This one here is called a Prodigy Connect. It has a tablet-like appearance. It is a tablet, actually. And basically, the tablet sits on top of the little tray, and then the child puts his book down here, and he can get his hand underneath, and he can do his math, he can do his reading. And there's a nice little camera. If you look at the bottom right of the screen, there's a nice little camera that can be pointed towards the teacher. So the kid can actually sit where he usually sits in class and not have to sit up front and actually see what the teacher is writing on the board. A lot of times we hear parents complain that, oh, my child is always getting up and going to the front of the chart. Of course, it could be that they're not corrected at all, and that's a whole different problem. But if they do have low vision, then, especially when you get to that middle school level, they don't want to be different. They want to look like everybody else. They don't want to wear devices. And a tablet looks has much more of a cool factor, right? It looks like a tablet. I'm bringing my own tablet to school, and I have my little stand, and it folds up very nicely, and they can just like unlock it and use it very, very quickly. So these are more usable for the more severely impaired, severe to profoundly impaired children. I have a few people that use it in college, but not as many. This tends to be more the preference of kids that are in middle school all the way up to high school, I would say. Portables are very, very popular, especially with older age groups and the middle schoolers and the high schoolers. Once again, the cool factor, right? It needs to look cool. It shouldn't look any different from the others because I don't want to be teased. Trust me, kids are just as mean in this country as they are there. Kids are kids. They'll be kids no matter which part of the world they're in. And so we have to bear in mind what kind of stress that they face so that we're not adding to that stress. The one on the top left here is called a Smart Lux. Once again, no financial interest here. It goes from 5 times up to 12 times. So there are about 4 magnification steps. The Ruby, this is a portable handheld Ruby. It's a 5-inch screen size. Once again, it goes about 3.5 times up to 12 times. The one down at the bottom is a 7-inch portable screen, which is really, really nice for children. It has a nice little leg, a stand, so you can just flip the stand down and then it stands up by itself so that they can put it on top of a notebook and just kind of move it around. 2 to 24 times magnification, which is very, very nice for most kids. That's about all they need. There is a nice little camera here that they can actually turn and use that to see the teacher. If the Prodigy Connect is not an option, then this is a very good option because they can easily just fold it down and put it in their backpack and get going, especially at the higher classroom levels or if they're in lab and they need to be able to see what's measurements and whatnot. All these allow them to manipulate the contrast sensitivity. Depending on their diagnosis, they may need black on white or white on black. So they find that extremely, extremely helpful. I have a lot of adults also that like both of the top 2 versions because they're very easy to use. Unfortunately, this one screams low vision, which is not the best as far as their acceptability range goes for children, but I do have quite a few people that use that. So moving on to distance magnification. So of course, handheld telescopes. Handheld telescopes are some of the easiest. They're monoculars ranging in power from 2.5 times all the way up to 10 times, 12 times. And if you want to get fancier, you can get even longer ones. Of course, the way with telescopes goes is the Keplerian telescopes tend to be the longer ones, the stronger the power, the longer the telescope, and at some point it is no longer usable as a low vision aid. It becomes a astronomical telescope, right? You can see the moon with it, but you and I aren't going to be looking at the moon all the time. Low vision patients want to be able to see bus numbers. They want to be able to see who's walking across the street or who is at my front door. So they tend to prefer the lower power ranges. I have a few patients that like the 10x, but once again, those are ones that like to go to games and want to be able to see their grandchildren play. These are handheld, which means they have to hold them up right against their eye, and then they can focus it and see what they need to be able to see. This is optical magnification. So the law of optics apply here too. So the stronger the magnifier, the smaller the field of view. Hand has to be stable. If the hand is not stable, then they will get shake, like an image shake, and that makes it less fun to use for prolonged periods of time. Maybe for a quick spotting. Hey, who's that across the street? You know, stuff like that. It is not a good option for wearing and sitting down to watch television because you have to hold it in your hand. These tend to be inexpensive. They're a great way to introduce magnification to children, school-age children. So when we start out, we usually introduce them to handheld magnification because it's very easy, it's quick, it's relatively inexpensive, and easy to replace even if they lose it. Binoculars like these are low-powered Keplerian systems. The lower powered ones have a very good field of view. So any Keplerian system is going to be superior in its field of view in comparison to a Galilean system. But Keplerian systems, you have to remember, the stronger powers tend to be longer. And when it gets longer, it gets heavier. So this one is very, very good for like a small room where they want to sit and watch television. It provides about 2.8 to 3 times magnification, up to 3.5 times magnification. It's pretty good. They can sit and wear it and watch television with it. Obviously, they cannot walk around with it, but I have some patients who will wear it around their neck and use it for shopping. Hey, what aisle am I on? What am I gonna buy? Or what does this particular aisle have? So for those purposes, these are pretty good. But of course, once again, limited in its capability. Bioptic telescopes are basically miniaturized telescopes, mostly Galilean, but sometimes Keplerian. I have seen a few patients wear Keplerian systems. These are small and worn above the line of sight. They're called bioptic telescopes because bioptics, meaning two optics. Straight ahead vision is just their normal eyeglasses, but on the top part, we put a telescope in order to allow them to see things far away. These can be worn monocularly, or they can be worn binocularly, as you see on the screen there. They can be focusable or fixed focus. We can also give them a little cap in the front in order to allow them to read their computer screen. These tend to be low, up to 3 times, maybe 4 times. The higher powered Galilean systems have a very, very small field of view, and that makes it really difficult to grind them as a bioptic telescope. This lady here is wearing a monocular Occutech 3X bioptic telescope. Pretty neat little device. It is a Keplerian system. If you can see here, there's a little black thing in the back, and then this little barrel comes out, and then it turns to the left and then comes forward again. So when she looks straight ahead, she sees like that. And then when she needs to use the bioptic telescope, she just drops her chin down and then looks through the telescope. So here's a wide range of changes in the technology, right? So bioptic telescopes, the first one, here's the designs for vision. We'll start down here. Here's the designs for vision bioptic telescope. He's wearing a 3X bioptic telescope in both eyes, mounted binocularly. The same thing, the main carrier has his natural prescription, his standard prescription, and then the bioptic telescope sits on the top. This lady here is wearing a Keplerian 4X, an Occutech 4X telescope system. The ocular is over here, and the objective is over here. So this telescope is actually mounted in front of the right eye, believe it or not. It's not mounted in front of the left eye. It's mounted in front of the right eye, but the objective is in front of the left eye. So there's a little bit of a learning curve there because of that parallax, right? They need to understand that, oh, I'm using my right eye, but the object is situated in front of my left eye. So there's a little bit of a learning curve, slightly harder to use, but has a very, very good field of view. The one on the top is a Beecher telescope, very, very nice system. And that's a 5.5 times Beecher that she's wearing. I have a few patients that actually drive with that bioptic telescope. I'm not familiar with the rules for driving in India, but in the US, you can drive even if you have low vision. Each state has a different rule. Not all states have the same rule. Some states don't even allow you to drive with a bioptic telescope. I believe Boston doesn't allow you to drive with a bioptic telescope. So, but some states do. Texas, for instance, does. And the patient wears that above the line of sight, kind of like how he's wearing it here or she's wearing it there. They use their natural vision to drive, and they simply drop their head to look at the street sign or the traffic signal for just a very brief fraction of a second, not even a whole 2 seconds. It's like maybe less than 1 second maybe. And they just drop their head down, look through the telescope. Oh, that's Smith Street. Okay, I'm come out. So they can't be looking through the telescope and driving or they're going to crash. But they use the telescope to simply drop their head, spot, and come right out. Very, very, very brief use. They have to be very comfortable driving with their natural vision. And when we fit patients for bioptic telescope, we always take into consideration what state they're in and what are the laws of that particular state. Some states dictate that their carrier acuity be 20/100 or better. Then if their carrier acuity is 20/200, they're out. They can't wear a bioptic telescope to drive. State of Texas doesn't state anything. It simply says through the bioptic telescope, if you get 20/50, you're cool. So which means you could be 20/200 and I can fit you with a 4X telescope and get you to 20/50 and we're home, so we're able to, so you really have to look at the state in which you practice and then fit these bioptic telescopes. The one over here is the Occutech Sight Scope, which is my favorite. Once again, no financial interest here, but I actually absolutely love it because it has little, what do you call there's a mounted track. Yeah, they have little tracks. So patients can actually grab onto the telescope and actually adjust it for their PD, which makes the fitting process so much easier and so much more friendly. And the whole thing flips out, which makes it very cool looking. All my young patients absolutely love it. It's only a 2.2 though. It goes from 1.7 to 2.2. Beyond that, it's not in that fashion anymore. Then they usually jump into this model of horizontal Keplerian or higher. This particular model actually goes all the way up to a 6-time. But my personal favorite for bioptic driving is actually the Occutech Sight Scope. The BIDA telescope, I don't know how evident it is on the screen that you're watching from, but if you can see this gentleman, this kid actually has cone dystrophy. So he's very, very light sensitive. So what we did with him was a 3-2-1 gradient tinting. The bioptic telescope is this tiny little spot right there. It's not even that conspicuous. You have to really pay attention to it. It's 2 little specks, and we mounted it flush to the frame so that the chunk of the barrel actually sits behind the frame. And we tinted it as a 3-2-1 gradient tint, so which means it's darker on the top and lighter as it goes down, so it blends in seamlessly with his face. He absolutely loved it. It's very, very difficult to fit. It takes a lot of patience and a lot of, exact measurements to get it to fit, but boy, was that a happy kid. But he's wearing it. So, that should be proof enough that sometimes ease of fitting is not necessarily the answer. It's about what that patient is willing to wear or not willing to wear. The Occutech Falcon, excuse me. The Occutech Falcon is actually a 3x telescope, also mounted as a bioptic, but it has autofocus capability, so you don't have to manually focus it. It's a pretty neat piece of device, but when you, and has a little attachment, it comes with a little battery attachment down that's on his lap. And then you can just, it focuses automatically at whatever distance he's looking at. And the RX is adjustable, of course. And when he's driving, he will need to turn it off. He will need to take the autofocus off. The state of Texas will not allow you to drive with the autofocus feature on. But here's what that looks like. Pretty neat piece of equipment for those that need autofocus capability and don't want to have to manually focus when they go from far to up close. How am I doing on time here? Oh, okay, almost there. The Geordie, I don't know how many of you remember the Geordie. The Geordie has made a comeback, actually. They usually don't look that happy, by the way, because it's fairly heavy on the nose, but it is an option. It used to look like that. And there's a close-up view of it. Believe it or not, I have one of these in my office. But it's kind of clunky, but it was one of the early head-mounted devices that we had available about 10 years ago. It's come quite some ways. There's an elderly lady using the Geordie. The new Geordie is pretty similar in design, but has limited capabilities when compared to the other ones that are out there. The eSight, which is on the top left of your screen, is actually has a white casing on the outside. It's a head-mounted display, has a battery pack, and that the patient wears. So it's connected by a battery, kind of like how the Occutech Falcon looked. And then there's cameras in the front. There are 3 cameras in the front. And then the patient sees the image through LCD displays on the underside of the glasses. So on the patient side of the glasses, he has 2 LCD displays. The PD is adjustable. You can put their RX in the back. It's a pretty neat piece of device. Ranges in magnification, once again, from like 3 times up to like 12, 15 times. The issue that I have found with that is just that the battery gets hot and the forehead piece kind of tends to get a little hot. They have redesigned it now, and I think the newer system seems to be better, and the battery seems to hold on better. Contrast sensitivity at higher magnification range is not quite as good as it could be, but I'm sure this just, as newer iterations come out, I'm sure that will be something that they will address. But the eSight is a pretty neat piece of device as far as electronic head-mounted devices go. The new eyes, the eSight also has voice-activated commands that they have come out with, where you can tell it, it'll tell you that, hey, I'm going to, it's 2 times magnification or 5 times magnification. The new eyes is pretty similar, has some OCR capabilities, optical character recognition capabilities. I haven't played too much with the new eyes. I've mostly played with the eSight. I played with the new eyes maybe for a couple of weeks. Another head-mounted device that's available to patients. The OrCam it's a completely optical character recognizer. There's no vision involved here. It's just an optical character recognizer. So the patient puts the patient has a little device here, and that's it. So he uses his finger, and when he makes a 1 or points to the paper, it just reads the paper for him. So there's no visual amplification. It's just purely auditory. It basically eliminates the need to use your vision. Pretty neat piece of equipment once again. The Iris Vision, we just got one a few months ago. We're yet to play with it fully. Similarly, similar to the eSight, provides head-mounted magnification. There's an LCD display back there. Has voice command. You can tell it, make it bigger, make it smaller, and then it just works with you, and it recognizes your voice and changes things. So that, my friends, brings us to the end of the talk. So I don't know if the future might look like that or what the future will look like, but I'll be happy to take questions.
Renji, I unmuted you. You can speak now.
Okay. My question is that if somebody cannot drive without the gadget, the registry of motor vehicles, they accept these gadgets and give the license for driving?
Yes, it depends on the state that you live in. In the United States, some states, about 26 states, allow you to drive with bioptic telescopes.
I
Yes.
see. I see. That's
But
good.
not for all acuity ranges, though. You
Oh,
cannot be no light perception or light perception and expect to drive. There are some inbuilt limitations there. The most you could go to is about 4 or 5 times, occasionally 6 times. By the time you get to 6 times magnification, the field of view is so small. It's just really hard to use. And patients themselves won't do it. Any person in good mind will do it.
Bhavani, can you comment about like between the Ruby and like with the portable electronic magnifiers, like your go-to choice and the cost part of it? How does at least here what does insurance do and what would you like potentially go for in terms
Okay.
of the optics?
So I have all the devices that I showed you in my clinic. And I try to match up the device with the patient based on their age and their goal. If it is a child in early elementary school, then and they need some sort of electronic magnification, then I like the simple Ruby. The small 5-inch Ruby is very good. If they need a little bit better quality magnification, a little bit better screen, then the SmartLux is a great option. For middle school and higher, the 7-inch Ruby is a wonderful option. I love it. For elderly patients, if they need anywhere from 5 to 9, maybe 12 times magnification, then the SmartLux Portable by Eschenbach is a very, very good option. A few patients have also liked the other tablet options, like the Optelec makes a very good option. Humanware makes a very good option. Explore is a wonderful option because for glaucoma patients where they don't need too much magnification, but contrast is an issue, the Explore starts at like 2.5 times, which is really nice for patients that just need that boost of contrast, but don't necessarily need too much magnification. And insurance doesn't cover any of them for anybody. Off late, we have seen that Blue Cross and Blue Shield covers it for some patients, but
So I'm going to, Aparna, if you don't mind, interject with a question which we got by email.
Mm-hmm.
This is from Dr. Lauren Ditta, who's a pediatric ophthalmologist from the University of Tennessee.
okay.
And she was interested in learning about your experiences in telemedicine, and I would like to actually request her to ask the question. Dr. Lauren, if you can unmute yourself and maybe articulate your question.
Hi, excellent talk. Yes, we have some colleagues, international colleagues that treat pediatric patients, particularly patients with low vision. And one of them had a question about, in particular, with the current climate, with the COVID pandemic, how might we be addressing patients with low vision via telemedicine, which may be the only way that we're able to currently care for these patients?
That's very true. We just started seeing patients through telemedicine about 3 weeks. So my experience is fairly fresh, but I can share with you what I did find was that patients are amazingly open to trying telemedicine. Um, as far as pediatric cases, I think the challenge is going to be just measuring acuity. What we do is we use a screen share option. So we have the chart pulled up on our screen, and then I just share that with the patient. And there are several different ways you can do it. You can email it ahead of time and have them print it out and stick it on a wall. And then you can talk them through it. If they can find a 10-foot space, then you can like talk them through that. Or what we can do is use a screen share option where if the patient or the parent can actually measure just the top, the chart comes with a little arrow on the top. It was designed by one of my dear friends and colleagues, actually, Dave Leverance, where he just created an arrow on the top, and all they need to be able to do is measure that arrow, length of that arrow, and tell you what that arrow measures on their screen, and tell you how far they're sitting from that screen. So it could be a laptop, it could be a phone, it doesn't matter. As long as we have those two measurements, we can actually measure their acuity with fairly good accuracy. And of course, you need to coach the patient with children. Once you get a sense of what their acuity is and will know what their goals are, the exam process is pretty much exactly like how you would do an in-person visit, except that in this case, you're going to pull out the devices, put them in a bag, and have them drive by and pick it up. And then we do a follow-up visit where we actually watch them use the device and give us feedback on how they're doing with it. And we can observe the patient, just like how you can see me, you can observe the patient, and we kind of coach them through it. It is slower, it is a little bit more involved, but that is how we tackled it in our clinic. We have a wonderful loaner library of devices. Of all the devices that I show in the clinic, I have an identical set, if not more, of those devices. I'm also part of a big university and have access to some grants that we wrote. That's how we were able to build the loaner library, but that's been a lifesaver for us. So we just give them the loaner devices, we put it in a bag, and they pick it up by curbside. And then we do a follow-up visit through telehealth. And I'm able to watch the patient and see how they're using it, for what purpose they're using. We know what different letter sizes are. Are they trying to read newsprint? Are they trying to read, their schoolwork? What letter size are they using? So based on that, we just guesstimate their magnification. Of course, it's not going to be perfect. You cannot measure scotomas and all that. You cannot measure. Some apps allow you to measure contrast sensitivity, but all the ones that I have seen so far have all been established patients. So I already know what acuity I'm expecting out of them. And if their acuity doesn't match up, then they hightail over to their ophthalmologist and say, hey, your acuity has gone down. You need to go figure out what's happening here. So, as a low vision specialist, my role is more to manage their functional aspect of their vision, and not necessarily the medical aspect of their vision. But if I see that their vision has dropped, then I immediately alert them and say, hey, you need to go see your ophthalmologist or optometrist or whoever you're seeing regularly, and have them manage that, and then come back to me. I hope that answers your question.
That was very
Yes, thank you.
Bhavani, there's a couple of questions on the chat, and one of them is from Deepak, and he wanted to know about how, in the time of COVID, how do you disinfect telescopes, and what's the protocol that's being followed?
Right. Well, alcohol wipes everywhere. We sanitize. The hospital actually has a specific protocol that we have to follow as far as sanitizing. We have 6-foot spacing. Everybody that comes in is screened downstairs, even before they get on the elevator. Everybody is required to wear a mask. If they don't come in with a mask, then we give them a free mask and before they're even sent upstairs to the clinic. Right now, we're seeing only 25% of our patients. So we're only allowed to keep one patient in a room at any given time. So basically one human being. So if they're at the front desk, there's just one person there. And as soon as they come in, we take them out of that room and move them into the exam room. As far as sanitizing telescopes and things like that, just the same way as you sanitize everything else. For any procedure, how do you sanitize? Exactly the same way. Alcohol wipes. We all wear face masks. We have N95s, and we usually wear a cloth mask on top of the N95 too, just so that, you, for whatever reason, I don't know why you do that.
And this was a nice question, very relevant to kind of what's happening with the current usage of children and iPhones and tablets. And so the question came from Pablo, and he said, is there any suggestion of a of like a magnifier or an app that goes with the smartphone, because these days the camera technology is so good and that it allows for good contrast, and nothing that costs more than 1K maybe, but something that we can suggest, that you suggest that apps are there.
I can actually share with Ram and you a whole page. Like there's a whole PDF of about 200 different apps on there. Not everything is appropriate for everybody, but I'm happy to share it with you so you can share it with your viewership.
Oh, that'll be fantastic.
That would be great.
I think I covered the questions.
Okay, I actually have, once the questions are done, I just wanted to share a little information about some devices from Vision Aid, but I didn't want to interrupt the presentation. So let's go through
one question, Bhavani, about IRA. Is that technology, because we had a presentation by the team a couple of years at one of the...
I love the IRA app. The IRA app is actually very similar to Google Glasses. So there's a little lens on the side. It's a camera that they wear, and it's an app subscription. So basically they subscribe to it, but it's like having somebody right next to you, but only they're looking through the camera and telling you like, oh, you're coming up to the men's bathroom, you know, so that they don't accidentally walk into a woman's bathroom, you know. It's like having somebody look through your camera and tell you every step of the way where you're going. A lot of places in the US, in Houston actually, are IRA enabled. Our Natural Sciences Museum is IRA enabled. The Hobby Airport is IRA enabled. So some places offer it for free, like the airport offers it for free, NASA offers it for free, but not all places. Some museums offer it for free, but otherwise it's a subscription basically. So they need to subscribe to it, and basically they have somebody sighted looking through their camera for them. It's a wonderful, wonderful option.
Ram, you can share. I think, Bhavani, if you unshare your screen, I think Ram will share his screen.
Yeah. First of all, thank you, Bhavani. That was a fabulous talk. I really learned so much. And I'm going to go back and watch the recording again once it's published. And I just wanted to take a moment, because we spoke about devices, just to give a shout out to a couple of people on the call and devices. So we have Mr. M.S. Raju. He's the president of Vision Aid India. And he's a graduate from the Indian Institute of Technology, the second batch. He actually designed this. This is a camera mouse from Vision Aid, our first electronic device. It's very similar to kind of some of the US devices, but it's a fraction of the cost. And actually, this was awarded by the Department of Science and Technology in India, one of the top innovations of India in its 60 years of getting independence. So at the 60th mark of independence, they published a catalog with 60 innovations, and this was one of them. So just wanted to give a shout out about that. And these are the other devices. I mean, one of the things we are doing is we actually place an emphasis on cost, and we're trying to basically drive down the cost to put it in the reach of a lot of people. You mentioned portable digital magnifiers, and you can see this one in the bottom. I'll see if I can actually hold this up on the screen. And we are actually currently distributing this in Arvind and Shankar Netralaya and Shroff and many of our partners. Can you see that, Aparna? I mean, is it visible?
Yeah, it is. Your virtual background makes it more interesting.
Okay, yeah. So it's probably not as effective over the video. But basically, this is like some of the portable magnifiers which Dr. Bhavani was showing. And the main thing here is the cost. I mean, this is a fraction of the cost. We are actually giving it to poor patients in India at 500 rupees. So 50% of this is actually given at 500 rupees, which is at today's prevailing rates, I don't know, is that like $7? Something to that effect. So that's kind of what some of the work we do. And really all of these devices, some of these are like devices for the blind and so forth. So since we have so many people from India, I just wanted to encourage you to reach out to us if you're interested in this, whether or not you're a Vision Aid partner. We are committed to making low-cost devices available. Actually, these are all distributed on a non-profit basis. So when we introduce these portable magnifiers in Arvind, Shankar Netralaya, and Shroff, this device was a third of the cost of their cheapest device, you know, and you know, the poor patients are getting it at 500 rupees. So it's a huge drop in the cost of devices. So just wanted to mention that there. And now I'll just hand it off to you back, Aparna, just to give a vote of thanks, and we can close this out unless there are more questions.
No, I think the only other question.
I just have one thing that I wanted to put in a plug for. The only thing I want to say is, you know, for your audience, that please don't think that one device is going to solve all their problems. It is not. It is still the package. It is still the whole picture. And there are so many new devices that they're coming out with every day. All I did was try to show you a snippet of what's out there, the most pertinent ones, that's all.
Mm-hmm.
And I hope I haven't offended anybody.
Oh, no, not at all.
There's one more question, a couple more things, and we're all driven around cost a little bit in India and how people are affording it. And Pablo's actually one of our ophthalmologists who's in Chile. And so he was also asking, is there a good way to contact you? And if it's okay with you, I'll share your email address with him.
Absolutely.
And then he can reach out to, and he wanted to have some ideas on what and cost effective too. And with respect to Ram, with Vision Aid, I'll put in touch with you also. If there are other ideas to explore. But I think that I think I covered all the chat-based questions. But Bhavani, it was such a pleasure. We've always kind of wanted you to be part of the Vision Aid team also in a big way. And I think this was a fantastic presentation. Thank you so much for your time. This is amidst COVID. We are all very busy, more busy than our regular lives, I think, that used to be with the commute. Even less the commute still, it's an interesting time around us. But I think this was a very, very nicely put talk, very easy to understand and grasp for most people. So we totally appreciate your time and going through all this.
Thank you. Thank you. Thank you all so much.
Ram, anything else to add?
No, thank you so much. I just echo everything which Aparna said. I think this, the way you presented the catalog of devices is immensely useful. We're going to publish this on the Vision Aid Online Academy as almost like a course, like a mini course. It's going to be a part of a course on devices. So a lot of people are going to watch this downstream. So thank you for sharing your knowledge and organizing it so nicely.
Thank you. My pleasure.
Good night, people here, and good morning to the folks in India. Have a good day.
Okay, bye everyone.
Bye, guys. Thank you, Bhavani.